Good morning, all of you. It's really a great honor and privilege to be a guest speaker and an honored guest, particularly with the president being Ricardo Corral. And I would like to tell you that this represents his direct line in many glorious people from the University of Pittsburgh, Center for Cranial-Based Surgery. And my sojourn there, we started with Dr. Vic Schramm, Dr. Gene Myers, who was a great supporter in addition to Dr. Peter Janetta. Then came Ivo Janica. We established the Center for Cranial-Based Surgery. And we never thought about our fellows as being ENT or neurosurgery, because very frequently the ENT surgeon will be doing something neurosurgical and the neurosurgeon will learn something about ENT. And our first fellows are, of course, here, Dr. Snyderman, and then my partner, Dr. Chandra Sen, was almost like a fellow for me for a year, but then he became my partner. And then came, of course, Dan Nuss, Ricardo Corral, Ihab Hanna, and many others. And one of the funny things I'd like to remember, always, Ricardo, we had a lot of fun times working together. One thing I wanted to tell you, you may or may not know this, I started toying with the endoscope, but really the idea of endoscopic skull-based surgery was started by Carl Snyderman and Ricardo Corral, working with Dr. Haerong Zhou. And that was the beginning. Of course, a number of others made major contributions, so you may or may not know this. In the old days, and I say old days, the North American Skull-Based Society was kind of small, and we would have maybe 200 to 300, and we'll have some seminars where there'll be 20 people. And I remember once Ricardo was on the panel, and somebody asked a question, and I was sitting there, and I said, Ricardo, you want to answer that? And Ricardo said, well, wait, I have to do a double translation. And I don't know if you understand what that means. He had to translate the question from English to Spanish, then think in Spanish, Spanish to English. But, that was so funny for me. But Ricardo gave a wonderful speech this morning. And in fact, I'd like to have a copy of that so I can study it a little bit more. So I'm going to talk to you a little bit maybe something philosophical. And after all these years, I think that I have the right to tell you something. So the issue is how to choose the right operation for your patient. What you do see up there is the Seattle Needle, which some of you might recognize either because the Sounders or the Seahawks, and that's what the University of Washington looks like. All those trees, cherry trees you see up there, were donated by a very grateful student from Japan who was so grateful that the University of Washington gave him the opportunity to study there. This was in the early part of 20th century. So every surgeon, all of us, most of us in the room are surgeons, some of them are not, and I really am so happy that you're here with us. We have several questions, of course. What is the diagnosis? Should this patient have an operation? And if you decide the patient does need an operation, what's the approach? What sort of team? Am I the right person for the procedure? You should be asking this question always. Should the tumor, if it's a tumor, be removed completely or incompletely? What's the adjuvant therapy? What's the follow-up? And most important question nowadays is, will the patient and I be happy after this procedure? Because at the end of the day, you want the patient to be happy, and you also want to be happy that you did the right thing. And now here I would like to talk about what's called the Symphony of the 7 E's. The number 7 is considered a magical number in numerology, and it stands for happiness, effort, and perfection, those who are numerologists. And by the way, today is the 7th day of February, I think. And also, I don't know if you know, what's the 7th planet from the sun? Anyone in the audience? Earth is the 3rd. Uranus. Perfect. Wonderful. Seventh planet. And of course, the most famous symphony, the number 7, is a Beethoven symphony. And if you can please activate the video. Can you play it? So, love of the Western classical music is an acquired one for me because I grew up in India. I had never heard in my life Western classical music until I moved to the US. But then when I heard it for the first time, something like a few gray cells in my brain clicked, and then I realized that this is something I like. But it always also embodies a lot of things that we do in skull-base surgery. You know, there's a teamwork. Every player has to play it well. At the same time, you have this person called the conductor who can bring out the best in the team, and someone who writes a symphony like Beethoven, and yet somebody has to play it well so that you can hear it. And then, of course, you have the people that appreciate it, like at the end of the day, our patients and the rest of the audience. So I have put together what are called the good E's and the bad E's. And just like everything in life, not everything about good is good, and not everything about bad is bad. And I'm going to go through them. So the first E is evidence. So this is all of our thinking, of course, should be based on evidence. And if you look at the levels of evidence, these have been now well defined. Meta-analysis of multiple randomized trials being at the top, a single high-quality randomized control trial, and then you have case control studies, cohort studies, large well-studied case series, and then so-called expert opinions and consensus statements, and finally, single case studies. Nevertheless, we hear a lot about this nowadays. Evidence-based medicine is all over the place. But it really is a combination of clinical expertise, best research evidence, and patient values and preferences. That's sort of what puts together so-called evidence-based medicine. Now, the problem is in skull-based surgery, we really don't have many or even one good randomized control trial. The reasons are many. These are rare tumors. Randomized control trials in general, by their nature, are very difficult to conduct, either in the US or internationally. They have limited population enrollment problems. It's a highly technical field. And then, of course, you have, even in good trials, you have people being operated outside the trial, funding difficulties, etc. And some of the results may not be applicable to real-world problems, such as the ISAT trial of coiling versus clipping for aneurysms. We have to use clinical judgment. And some trials are badly conducted with bad conclusions. An example was the Aruba trial for unruptured AVMs. However, if one were to conduct a trial, one can ask many questions. For instance, one should a clivus chordoma being seen for the first time be removed totally, or can you accept subtotal resection with radiation? Similarly, microsurgery versus radiosurgery for vestibular schwannomas less than 2.5%, 2.5 centimeters in size. So the end of the day, we can say that randomized control trial information is not available for skull-based tumors or lesions, and surgeons will have to decide without class 1 evidence. So when you talk about class 1 evidence, then you move on to the next 2 E's, the first one being experience. Of course, we all start accumulating both good and bad experiences immediately after we are born. And some believe that our experiences are cumulative across many lives. You may or may not believe that. Experiences relate not only to surgery, but also to people, learning, life, all of which bear on our practice. However, with respect to surgery, something magical happens, I believe, after you pass your 50th case and your 100th case. These are not absolute numbers, but certainly it has some real influence on your practice. Expertise, on the other hand, is something that you gain when you learn from both good and bad experiences. In other words, you get to be a better and better person if you carefully study yourself, your results in a very careful way. You also look at other people's results, and that's the function of our North American Skull-Base Society. You also develop something called judgment, which is really expertise. And some, of course, are able to learn better than others. And this quote, which is misattributed to Albert Einstein, says, "Insanity is repeating the same thing over and over again and expecting different results." The last good E is the very important E, and that is the expectation of the patient. So the question is, what does the patient want? Complete tumor resection or does not care? Preservation of all functions, but it's more interested in having a cure. Wants to return to work as soon as possible or wants to remain disabled after surgery. We know some of our patients who do this and get money from taxpayers. Whatever it is that the patient wants is charmed by minimally invasive surgery or no, and most patients ask you, "Doctor, can you cure me just with some medication, pills?" Now we come to what I call the baddies, and not all of these are really bad. Emotion is very important when we make a decision. The question is, should the surgeon treat the patient as a member of your family, his or her family, or be detached and yet empathetic to the patient? Many patients, by the way, ask me in my office, and I'm sure you've had the same experience, "Doctor, what would you do if I were your wife, child, or husband, whatever?" And I always give the same answer, and my residents and fellows, I think they like this answer from me. I always say I would find the best surgeon possible to treat this patient other than myself. This is because I need to be emotionally detached, and I can't make the right decision if you were my wife or father or mother, whatever. And of course, most surgeons will not operate on a member of their family for this reason. We come to the next E, that is the ego. Ego is important for surgeons because it makes us what we are. It includes the confidence that we need in order to do our job every day. This is the difference between surgeons and medical doctors sometimes. We are decisive. We know what we are going to do, and we do it, good or bad. However, an overinflated ego clouds our judgment. So each one of us needs to realize our limitations with regard to patients and diseases. We need to know when to stop, or rarely, we also need to know when to refer the patient to another specialist or another surgeon. And that, again, is called judgment, comes quickly to some and only after a lifetime to others. Now, the last one, emoluments. So none of us, of course, chose our profession in order to be poor, or we can't take care of ourselves or families. However, money grubbing, overcharging, charging for procedures we didn't do, or performing unindicated procedures, all of these things, we see examples of every day in our lives. They certainly don't do well for our profession. Sometimes they may land us in jail. However, many versions of still legal excesses are prevalent. So at the end, we need to, I go back, I'm very philosophical about many things, but I go back to the Bhagavad Gita whenever I have a real question. It says, perform your duty. Our duty is actually to help our patients, number one. Number two, to teach the next generation. Actually, number one should be our duty is to ourselves and our family. Then this duty is very important. So if you perform your duty but don't look for the results or don't look for the fruits of your action, that means that don't think about what's the gain to me all the time. Do your duty properly. So I'd just like to show you one case example of how a recent case, now how did this happen? And did I apply my own principles to this patient or not? Here was a 58-year-old patient who came from Greece, who had been previously operated by me, I think about 15 years previously, for a skull base grade 1 chondrosarcoma. At the time, she had an apparently gross total resection. She lost hearing in her right ear. I think she already had poor hearing, lost hearing completely, but otherwise she was well. She presented with a history of severe ear pain, headaches, difficulty walking, vertigo, and some difficulty swallowing. On exam, she had poor hearing in the right ear, right mild facial numbness, no tearing in the right eye. She had lost her greater GSPN during the previous surgery, and cranial nerve 12, palsy, and decreased cranial nerve 9 and 10. So she had a lot of deficits. But the social history here is very important. She's a single mother. She works full-time as a teacher. She cares for her highly functioning, slightly autistic son. She wakes up at 6:30 in the morning every day, prepares breakfast, takes her son to school, then goes to work. She returns from work at 3 o'clock, picks up her son from school, prepares dinner, sometimes goes out with him, and then she gets a lot of headaches and ear pain by the evening and goes to bed by 9 p.m. So in order to check out this patient, I decided to make a house call. So I actually visited her in Greece. Not exactly, but I did make a visit to Greece, so I happened to also see the patient. And you see her son, and then that is my youngest son, Krishna, and then Daniela, my daughter, standing there, and then we had a wonderful trip in the boat, etc. But that's the patient and her son, who is highly functioning. Even though he's slightly autistic, he can, if you tell him the date of your birth, let's say mine, November 7, 1951, he would tell me exactly what day it was in a fraction, within seconds. I didn't know how he could do it. And my son, by the way, is a geo-whiz. He got geography. He won the GeoB several times. And he had a better knowledge of geography than my son. So he's not really, I don't know how you define that. But anyway, this was the tumor, and you can see that, of course, it involves the petroclival region, the cavernous sinus on the right side, and also involves the jugular foramen quite a bit. And we did, because the carotid artery was involved, we did also an angiogram and a carotid compression test. It does show a slightly delayed filling on the right carotid circulation. So the questions here really are, obviously, the patient wants complete removal. That's what she wants. And she's going to travel again all the way from Greece to Seattle to get this done. At the same time, she wants 100% preservation of her quality of life, not only for herself, for her son. So I operated initially via a subtemporal transzygomatic approach, inter and extradural. The problem was that all the anatomy was distorted. None of the typical anatomical landmarks were present. But we worked through the cavernous sinus. It was endoscope-assisted microsurgery. I was able to remove a lot of the tumor, but tumor is left in the cavernous sinus and the jugular foramen. So the question now is, I could have done at this point, I was thinking about endoscopic transpterygoid surgery and various permutation combinations in my brain. This is what I do when I tell my residents, I do all of these operations in my brain, and what is the potential outcome, how long the patient will stay in the hospital, et cetera, et cetera. So endoscopic endonasal removal or 2 additional stages of tumor resection, and what about postoperative radiotherapy, proton beam, which would be appropriate this time. So finally, I made a decision to perform a far lateral retrosigmoid approach because one of our very important symptoms was lower cranial nerves. So when I got in there, I found that the tumor actually had invaded intradurally, and all of the lower cranial nerves and the vessels were involved in the tumor. As you see here, this is the operative drawing showing the vessels in case. So we got all this tumor out. So she is left with some residual tumor in the cavernous sinus and clivus. This is, I would say, not the optimal result that I would have wanted, when I'd seen the patient for the first time. I would have wanted absolutely complete resection. But for this patient, I thought that this was a good result. However, despite this, she didn't stay in the hospital only about 10 days, but she had a PE, and she got an IBC filter. Luckily, we caught it early, and then she discharged. She had a partial third nerve palsy. And she sent me these pictures while she was enjoying a holiday. This was about a month ago. She sent me a picture yesterday where the third nerve is completely recovered, and she's fully ambulatory, etc. The question is, how did I do? So, was it evidence-based? There's no level 1 and level 2 evidence available. Level 3 evidence suggests that skull-based chondrosarcoma, subtotal resection with proton therapy is effective for long-term control. Now, this is already recurrent. What about the patient expectation? This patient wanted everything, and that's pretty much what many of our patients want. They want everything. Complete tumor resection, but no deficits. I did what I thought was the best for the patient. What about emotion? I was probably more attached to this patient than I should be because of my previous, interaction with her, and plus I saw her in Greece, etc. However, I acted according to her need rather than her request. And this is going to be a very difficult thing in these days to sell to your administrators, because they are looking for the paper where the patients fill out that they are satisfied, etc., when they see you in your clinic. But as a doctor, at the end of the day, you have to make the right decision for the patient. And of course, this is a special circumstance. She came from a long distance. There is no room for error with this patient. So already she had pulmonary embolism. Luckily, she recovered from all of that. So with that, I'd like to conclude and thank you very much. Once again, Ricardo, thank you for this wonderful opportunity and also to see North American Skull-Based Society. We started, I would say, a small group in Colorado, Denver, Colorado, 20 people. Now more than 1,000. It is really a great accomplishment. And I'm truly proud of you being the president of the NASBS.